We're going to go into now transition-related grief. I think a lot of the concern in the field is around this area operating without typical safeguards that are usually in place for young people. And the concern is really around risk for those young people, really boils down to the way that this field is operating, potentially leading to harms that can be avoided. And so we're going to look into right now what those harms can look like. I'm going to share the definition one more time so that's top of mind. The anguish and despair that emerges for a person as a result of physical and psychological injuries and significant losses sustained from medical transition. Important to just start off by saying that this is a newly emerging clinical phenomenon and clinical issue. We're very much in the early stages of building a knowledge base around it, and our understanding of it is still evolving. And because we lack effective ways to identify and assess how this is being experienced and expressed, we don't yet know how common and extensive it is. There is a lot of shame associated with this experience that prevents people from seeking mental health support or engaging with research. And so it really remains underreported and poorly understood. And because of this, we can't make assumptions about the people who experience transition-related grief. It's a diverse patient population of unique individuals who hold a variety of experiences and perspectives, including as they pertain to personal beliefs around gender and around transition. As I speak, you'll notice that I don't use the noun detransitioner. This is a word that has been widely adopted and used everywhere from the mainstream media to academic literature, but I don't think it captures the diverse and multi-pronged experiences that exist. And I think it risks leading to generalizations and limiting the appreciation of the wide variety of experiences that people go through. And I also worry that it hinders the processes that people have to go through in order to heal and move on with their lives. If they're sort of seeing themselves or identifying themselves through, this one experience or as a detransitioner. So when I speak of detransition, I use person first language and I speak of it in terms of a verb. So something someone does, process someone goes through, not as a noun, something that someone is. Transition related grief always involves some form of medical harm. The realization that transition has started to harm you is experienced as a traumatic event. I think a lot about the work of Judith Herman, whose work focuses on understanding traumatic stress. She described traumatic events as involving threats to life and bodily integrity that evoke the response of catastrophe, bringing about unwanted and unwilled, overwhelming emotion in the face of helplessness and aloneness. So the medical fallout that may be present can include incontinence, sexual dysfunction, a compromised endocrine system that necessitates lifelong medical dependence, as well as novel medical issues that doctors lack adequate knowledge to address. One such issue is urinary fistulas that expose the prostate. How do you address that? How do you medically or surgically intervene without potentially harming the patient further? It's important to note that distrust in doctors and therapists is prevalent among people who are experiencing transition related grief, especially towards professionals who were involved in the initial interventions or who practice in a way that endorses rapid medicalization. And yet, people who are experiencing this are often dependent on the very professionals and system that they feel cause them harm, especially when gonads have been removed or surgical complications need to be addressed. And this reliance can really exacerbate distress, especially when it's clear to the patient that their doctors don't know how to really help them once they recognize that everyone involved is in uncharted territory. Transition related grief does not always involve detransition and is distinct from detransition. Detransition is the physical process of reversing a previously initiated medical transition and is an attempt to undo, where possible, the effects of medical transition on secondary sex characteristics so as to live socially within one's natal sex again. It's one way some people choose to move forward. Research on detransition is limited, and we currently don't know how many people undergo this process. Detransition doesn't always involve an experience of medical harm or grief. There are those who detransition who report no feelings of harm or grief. And just as therapists should avoid assuming that a patient's gender dysphoria automatically means that they benefit from medical transition, therapists shouldn't assume that someone experiencing grief or reporting harm from their transition will or should detransition, or that detransition would be the most beneficial step for them. Those experiencing transition related grief may not detransition for a number of reasons. For some, the physical changes from transition are so significant that it would be impossible for them to detransition. They'll never again look like their natal sex. Detransition is also a very challenging process. It can be incredibly grueling and really demands a lot of fortitude, determination, and a lot of scaffoldings of emotional and social support. And as a result, some people choose not to pursue it simply because it's too difficult. And they may feel like they lack the emotional capacity to adjust physically, hormonally, and socially after having lived in a transition state for many years, which has really shaped them not only on a bodily level, but also psychosocially, often during really important developmental years and periods. I'm going to talk a little bit about transition regret. Often this experience is referred to as transition regret, and I'm pretty critical of this framing for a few reasons. Those experiencing transition related grief report that they weren't given a true informed consent process, that they weren't helped initially to understand what it was that they were dealing with and what their options for addressing it were. So there is serious question about whether a true informed consent process and genuine choice were really present and involved. And so with that in mind, when I think of regret, I think of choice, I think of agency. I think regret implies choice and agency. To experience regret about transition, one must have genuinely experienced choice, which a medical environment that promotes a singular treatment option really doesn't provide. I'm also critical of calling this experience transition regret, because regret also implies a negative emotional state that is stable and unchanging. Regret is a static, depressive state. And people don't want to live in a state that's in a static, depressive state and an experience of unchanging remorse around an aspect of their life that's so big. And I don't really think that human psychology can afford that. And so I think that therapists should be aware that it's quite likely that the patient will ultimately not express regret about their transition. And this is because it's actually psychologically healthy for the patient to turn this very painful experience into something that is a strength within themselves, which helps the individual move on and build a life worth living. One can experience things about transition that they regret and moments of regretful feelings, but defining the whole experience of transition, which is now imprinted onto their body and may require daily management of complications as regret, I think would be an emotional deterrent to their therapeutic process. And I think that the patient is likely to fight it, as they should. And, if they don't fight that, then they don't have the spirit to survive, which is really necessary for them to be in touch with. So when it comes to regret, we help the patient identify where the regret is actually located. An example of that might be that the patient regrets having trusted so easily therapists, doctors, a medical system. So moving into looking at the therapeutic work and what's required for therapists to be prepared for working with this. The initial acute stage can actually last a long time. And working through it is really a non-linear process where progress is experienced as two steps forward, one step back. It can be incredibly dark at times, and it can be a very disorienting period, and it requires significant therapeutic containment. Much of the work is really in helping someone cultivate patience and tolerance as they confront their experience and work through their experience. And a lot of the time, the grief that is present and working through it can at times involve periods of non-functioning and dark moments where someone is feeling very stuck. And so the non-linear nature of the process can actually work to help patients perceive that there is some progress, even amidst moments that feel like backslides. Suicidality can emerge, and themes of mortality, dying, death, these can come forward as part of themes in the therapy, as well as fears for long term health. And during this period, the individual is reflecting on how they got here, why they transitioned, what transition has meant for them or means for them. They're really confronting the realities of their physical body, the limits of nature and medical technology. They're working to accept life as it is now and learning to work with what is rather than fighting what can no longer be changed. And very much mourning the body that they once had and never will have again, and also the body and life that they imagine they could have had. I think it's very important for clinicians working in this area to be adept in grief work. I think that that's really a necessity. And they must be comfortable sitting for long periods of time with people who are suffering through deep emotional pain. They also have to have the right support systems in place. There can be a lot of transference involved in this work. And so they'll have to be incredibly diligent in dealing with their own countertransference and in holding their own subjectivity. The material in sessions can really bring up very strong emotions for the therapist. And so regular supervision is something that I think is very important. And it's possible also that peer supervision groups may be really necessary and possibly even personal therapy depending on what gets provoked in the therapist emotionally. Therapists should be really careful not to impose meaning on the patient's experience and should focus instead on helping the patient to come to their own meaning. A lot of the time in this area, you hear stories about therapists saying to patients, well, this means that you're really non binary, or this means that, your gender was just more fluid than expected. This is really the therapist imposing meaning onto their client's experience, which can really get in the way of their client's process. So, very important to avoid that and to really stay as neutral as possible and hold a neutral, open space for your patient to have their own process, come to their own meaning. And it can be very tempting to try to uplift a patient's spirits through reframing, but it's a very slippery slope and can be antithetical to the therapeutic process. The patient really needs to be with their suffering so that they can move through it in order for it to be resolved. And so therapists must be really careful with any impulse to try to quickly alleviate distress or even around trying to alleviate distress at all. Really important to just sort of be with the pain, be with the suffering, really join them in that and not give them any reason to believe that you are scared of it, that you can't tolerate it yourself, that you can't be in it with them. It's really, really important to just hold space.